What I'd like to do today is talk about instrumentation for audiology and the decision paths that you would take to come up with a good choice. I can tell you a story about an audiologist who started working for an ear, nose, and throat doctor. She had just graduated, and this is only a few years ago that this happened. And she starts working for this physician, and he had a nice office that he had equipped. He had another audiologist confer with him on what type of equipment should be in this office. And so she starts working there, and she'd only been there for a couple of weeks when the management of the hospital asked her if they could have a meeting with her. It ends up that the ear, nose, and throat doctor that she worked for didn't own the practice. He ran the practice, of course, but it was owned by the hospital, the local hospital that was across the street. Anyway, in that meeting, she met with the purchasing agent as well, and they informed her that the hospital was opening a multi-specialty clinic about 10 miles away, and that they were going to have ear, nose, and throat in that clinic, and ear, nose, and throat was going to have within it audiology, and they were asking her to provide them with all the information they would need to build and acquire an audiology clinic. So she then was scared to death because she had never done anything like that. Luckily, she got a hold of us, and we worked with her and the ear, nose, and throat doctor to acquire the right equipment, and it's a very successful practice right now. And no matter where you may be, there's going to be some distributor of audiological equipment in that particular geographical area. And you might get lucky, and it's a good one, who has a lot of experience and knowledge of all different areas, or you might get somebody who has relatively little or no experience, and you might get a pure sales guy, that just wants to close a deal, So it would be good, because most audiologists graduating really don't have any experience like this audiologist who, after 2 weeks, had the responsibility of specifying everything, including the design of the room that the booth would be in and any other space that was going to be in this facility, which they were going to build. She was had to write all those specifications, and so it was a daunting task, and she got through it because she was able to rely on the local distributor. But there are many people who have done that, and it was a total disaster. So that's why it's good that we're doing such a thing. All right, so that's what we're going to be talking about. And so if you were putting together a complete clinic, whether it's your private practice or like this audiologist that had to specify the instrumentation for a clinic that the hospital was opening, where would you start even? The best way to start is to figure out what is your core equipment. What's the core equipment? What do you have to open the door and see your first patients? And what's in the core is going to depend on where your patients are coming from, right? The first thing that we had to do when I was helping this audiologist with the task that she had to specify the instrumentation for the clinic is we had to meet with the ENT that was going to be there, and we had to find out from him what type of tests he would be ordering. Would he be ordering vestibular testing, for example? Well, some ENTs, they're all over that. Others say, oh no, it's the last thing I want to see is a vestibular patient, all right? Well, if that was the case, then vestibular equipment wouldn't be in the core. So, what is in the core equipment? Well, if we were thinking about that now, we would look at this list probably from top to bottom and start thinking about it. First of all, a test booth. Well, that's automatically in the core because it would be very, very risky to try to have an audiology clinic and no booth. In fact, you couldn't meet the ANSI standards for hearing testing without some kind of booth that is especially designed for such a thing. And then continuing on our list of core equipment, of course, we'd have an audiometer. There'd be no question about that. You wouldn't even have to talk to the doctor. Obviously, you're going to have an audiometer, but what kind of audiometer and what kind of testing is the doctor going to order? Is there any kind of special testing that might make a difference in the audiometer that you choose? Of course, you'll have a tympanometer or a middle ear analyzer, and there is a difference, and that also is going to depend on what type of tests are ordered. Naturally, if you're in private practice, you might want to consider, well, I better get something that does the most popular testing, that would accommodate pediatric testing as well as adults, and that would do acoustic reflex, both contralateral and ipsilateral, at least because people referring to me, and one thing you want to do in business is build your referral base, people will be ordering these things, and I'll have to be able to do them. Audioacoustic emissions. Most audiologists would consider that part of their core. In other words, they couldn't open the door, they couldn't start seeing patients without that on the list of equipment, especially if they were going to see pediatric patients, right? Well, am I going to fit hearing aids? Am I going to dispense hearing aids? If so, then naturally you'll need NOAA, right, the platform program that all the manufacturers use. You'll need HiPro, right, a universal programming device, and you'll need the fitting software for each manufacturer that you're going to use in your dispensing practice. If you're going to be dispensing hearing aids, will you be doing real ear measurement as part of your dispensing practice? If you went out and, if I asked that question right here, how many of you feel that you would be using real ear measurement to dispense hearing aids? Yeah, I think all hands would go up, because here at Auburn, that is part of the practice. It's part of the specification of dispensing hearing aids. However, if you were in metropolitan Atlanta and you were opening a practice in metropolitan Atlanta and you were to poll people who dispense hearing aids, both audiologists and non-audiologists, you'd only find maybe that 35% of them use real ear measurement in every hearing aid fitting. So you'd have to make that decision. Am I going to use real ear measurement? And am I going to fit pediatrics? Am I going to fit kids? Especially young kids, toddlers even. Will that be part of it? Because that's going to help you specify which real ear measurement equipment would you be using. Would you be getting that VeriFit for 13 grand? Or could you maybe get a MedRex for 5? Yeah. Makes a difference. Will evoke potential be part of your testing? Will there be doctors, either the doctor that you're working for or one of them, or doctors that will be referring to you, will they be ordering ABR, electrocochleography, CVEMPs and OVEMPs? If so, then certainly you'd have to have equipment that will accommodate all those things. What about vestibular testing? Will you be doing that? And if so, what would you need there? Would you need a VNG system? What's the difference between VNG and ENG? And would you be including VHIT, video head impulse testing, in your vestibular lab? And there's other questions too. We'll go over each one of these things individually. And what about a video otoscope? Many practices have those nowadays, and just as many don't have them. So there's a lot of questions, but the thing to do, first of all, the place to start is, what is that list? Like the list you made of core equipment, things that you need to open the doors on the first day. You might decide that the core equipment only comes down to here, and that you're not going to invest in evoked potential and vestibular equipment until you have somebody, if this is a private practice, until you have somebody that is ordering those tests, until you have a physician. I know an audiologist who years ago started a practice in Gadsden, Alabama. And when she was coming up with the core equipment, it came all the way down to here. And then when I said, what about evoked potential? She goes, oh no. She was an Auburn student, by the way. She was an Auburn grad. She says, I am really not into evoked potential. I said, well, then I guess you're not into vestibular. She goes, nope. So I said, that's fine. To each his own. And we equipped her practice with the other equipment. And then when the practice grew, she had to duplicate this because she wanted to have two booths that had all the equipment in, because she had hired another audiologist to work there with her. Everything was fine until a doctor bought a practice that was across the street. The practice across the street didn't do testing and referred all of their patients to this clinic. And the older doctor retired and sold the practice to a young physician who had recently graduated. And so she went over with a bottle of wine and everything to make nice with the new doctor and invite him to continue to refer patients. After all, it was right across the street. And the doctor said, well, I would be glad to. I understand that this was the way this practice had operated. And since you are right across the street, and she said, and we would give your patients priority. We'd make sure that they've got appointments within very reasonable amounts of time. And if certain ones were necessary, we would see them right away and fit them in even. So he loved that. And then he started asking what type of testing, air conduction, bone conduction, SRT, word discrimination, all of these things go, tympanometry, acoustic reflex, ipsilateral, contralateral. He was naming all these things. She's going, check. Everything was fine until he said electrocochleography. It was, okay. And she said, yeah, got it. She didn't have it, but she wanted to say yes. He said, good. And auditory evoked potential, auditory brainstem response. She said, yep. And ENG testing. At that time it was ENG and not VNG. And she said, yeah, we got vestibular. And so the meeting ended, and she ran back to her office across the street, and she called me and she goes, you won't believe what just happened. I got to get this stuff quick, because he's going to start sending patients and want them done right away. And she hired somebody else to do that because she wasn't into it. Anyway, but she knew her core equipment, and she did well with that, and added the other equipment when she had a referral source that was going to provide her. In fact, she asked him, how many ENG vestibular tests do you order in a week or a month? And he said 3 or 4 a week. And she said, okay, the equipment will pay for itself then, relatively short period of time.